Welcome back to Between Two Bushes. Hi, I'm Dr. Stephanie Schull, the inventor of the Kegelbell, and we have a really exciting mini-series with guest starring the Vagina Coach. So thank you, Kim, for joining us for this mini-series. We really appreciate you sharing your expertise. And today I want to talk about a topic that really is elusive to most people. When I say the word prolapse, pelvic organ prolapse, it just kind of goes over everyone's head. And, you know, it's really amazing to me that we've just kind of don't have this information at the ready for us. So today I want to talk about what is it, how common is it, and, you know, let's just start there. So
yeah.
Pelvic organ prolapse, how common is, what is it and how common is it?
So it's actually, statistically wise, it's more common than incontinence. And I had never heard of prolapse until I think it was about a year or so postpartum after my second. And I was in a meeting with two doctors and I was talking about that medical device that I have. And I was trying to increase awareness about it. And they were quite intrigued. And then they said, oh, well, can this be used with a cystocele? And I had never heard of the word cystocele. So I said, I'm not sure. What's a cystocele? And they said a bladder prolapse. And then I was still like, what's a bladder prolapse? And so that was kind of my introduction. And then when I started to work with pelvic floor physical therapists, I started to learn in great detail about what it is. And statistically, well, actually, let me talk about what it is first. So what happens is, I'll get my model back here. So here's the pelvis, here's the pelvic floor muscles underneath here. And here is the bladder, the uterus, and the rectum. So this is a female pelvis, female anatomy. Those are the three organs. And part of the function of the pelvic floor is to help keep those organs up where they're supposed to be in their normal anatomical position. For a variety of reasons, they can sometimes start to shift out of their anatomical position. And what can happen is they can descend into or bulge into the vagina. So if you can, usually I have a sweatshirt, but I don't have one here today. But if you can imagine that this is the vagina, the tube of the vagina, we have an anterior wall, we have a posterior wall, and then at the top we have the uterus. And so in a bladder prolapse, also called a cystocele, or also called an anterior wall prolapse, what happens is the bladder starts to shift out of its position and it will create a bit of a bulge into the front wall of the vagina. And early stage prolapse, so prolapse is typically graded from 1 to 4. Grade 1 would be just a tiny little bulge. Grade 2 would be a little bit more. Grade 3 would be where it's at the entrance to the vagina, and grade 4 would be where it's out. So that would be the stages of a bladder prolapse. In a uterine prolapse, it is sitting at the top of the vagina. So we have the cervix and the uterus, and it can start to descend into the vagina. So it's not necessarily bulging, right? It's descending into. So again, it can go through the various stages to being completely out. Well, it doesn't fall out, but it can be bulging out.
But it's out. I mean, it can, and that's fairly rare that we get the third or fourth degree. And much more common first and second degree.
Yes, for sure. So posterior wall prolapse is also called a rectocele. So that's where the rectum bulges into the back wall of the vagina. And it's not called a rectal prolapse. A rectal prolapse is when the rectum bulges out of the anus. And that's something that can happen to men or women. And in terms of statistically, I actually need to look and see what the latest stats are on which one. So bladder is typically the most common. Uterine is pretty close there. Rectoceles are not quite as common, but over 50% of women have some degree of prolapse. And a more recent piece of research came out and looked at in the early weeks. So at 6 weeks postpartum, they looked at women who gave birth vaginally or by cesarean. And over 80% of women have some degree of prolapse at 6 weeks postpartum, regardless of their mode of birth. And of that 83%, 50% of them have a grade 2 or greater. So it's incredibly, incredibly common. and nobody is talking about it. Nobody talks about it before. Nobody screens for it after. Nobody's giving any recovery strategies for it. And because early stage prolapse is often asymptomatic, and after we've given birth, there's a lot that has changed and we are feeling all sorts of things. So we may not associate something that feels a little odd as odd. We think, well, it's just because I just gave birth. And in the society we're in now that is applauding people getting back to the gym at 2 weeks postpartum and posting the selfies and not looking like they've had a baby as fast as possible, that coupled with the fact that most of them already have a prolapse, then there's the healing hasn't happened. And so an exacerbation of that prolapse is very, very likely.
Yes.
So it is incredibly, incredibly common, but way less talked about than incontinence.
Yeah.
And the other thing to consider is that we, the shame, so we talk about the shame with incontinence, but the shame associated and the mental health aspects associated with prolapse are much more significant. It's hard for people to accept because they've never even heard about this before. And oftentimes it's affecting their confidence, their self-image, their relationships, their sex life, their fitness, their everything. And most people feel like, oh my God, my body's broken. I can't move. I can't do it. The only thing is surgery. So really, really common, but, and way more devastating, I would say, than incontinence.
Yeah. Yes. When I talk to people about pelvic floor exercise and what it can treat and prevent, it's usually the three things are incontinence of various forms, urine leakage, gas leakage, fecal leakage, prolapse of the three forms, the uterus, the rectum, or the bladder, and then sexual function. And I talk about the subsets of that. And when we market or advertise or try to have conversations with the public, I wanted to talk about prolapse, but it doesn't get anywhere. It doesn't communicate well with people because they don't know what it is. And because you said it's a cult, they can't see it or really feel it until almost too late in most cases. So that first and second degree or stage, they're not aware of. And what's fascinating to me is like doctors really aren't alerting people.
Yeah, well, the frustrating part is that there can be some people who have an early stage prolapse who they are very symptomatic and they are seeking help and they're trying to understand it. And then there's other people who have no symptom, no awareness, no nothing until it is a stage 3 potentially. And then they wipe or they feel a bulge and they're thinking, what the heck is this? So symptoms don't necessarily equate the severity or the stage of a prolapse. I have a stage 2 rectocele, so my rectum bulges into my vagina, and I have been symptomatic, but I have done a lot of things to now be, for 99% of the time, asymptomatic. So you can get there. It's not too late, but catching it at an early stage is really, really important. And so right now, people, if they have been told that they have a prolapse, especially if it's with, and I don't mean to bash the medical community, but I hope that there's more collaboration with pelvic floor physio and the medical community. If they would refer on to pelvic floor right away, ideally every single person who's given birth to a baby would see a pelvic floor physiotherapist, but also not say, oh, well, you just had a baby and that's just now how it is. And so some doctors now equate a stage 1 prolapse as normal anatomy after giving birth. And so while, yes, that can help normalize it for some people, it's also doesn't put people in a position of power to address it proactively. They just have to sit and wait until it gets worse. And then people are afraid to move. So then they have other health conditions because they're not moving and exercising, and they're just waiting for this to get so bad that, okay, now I need to fix it with surgery. But there's so much we can do in the meantime to reduce the symptoms, potentially reverse early stage, especially bladder and uterine prolapse can be either improved by stage or completely reversed with the right information. But that information just sadly isn't getting out there yet.
Yes, you're right. Because it's so ubiquitous, it's seen as almost normal by the medical community as well. And doctors have as a litmus test, I mean, it's part of the medical profession, it's baked into it, to ask, is it a problem? And if you're asymptomatic, it's not a problem. So it's going to not be, nothing's going to happen until it becomes problematic.
Right.
And so that's why that prevention piece is so hard in that equation. An earlier episode of Between Two Bushes, we were talking with one of Kegelbell's first customer. In fact, it was our first customer.
Yep. And
she is an Ironman triathlete. And she was very aware when running after her first child that she felt something descending, dropping, like something was going to fall out.
Yeah.
And so using Kegelbell helped her, address that, treat that, so that she can run the ridiculous number of miles, and by the ridiculous number of miles they do in a full Ironman.
Yeah.
And come in 6. I mean, she's like amazing.
Wow, that's amazing.
And so, so it is addressable in many instances, especially if caught early on. And when I survey Kegelbell customers and I say, why did you buy it? What are you looking for as far as benefits? And I'll list like generic things like vaginal health, which is fairly generic, or I'll put something very specific like bladder leakage. And I'm just curious. I put prolapse on there. Almost no one clicks the box, but we know pretty much everyone is going to have it. So that I hope that people watch this episode and really.
And I think the other thing to think about too is there's lots of things that can contribute to the development of a prolapse, but it can sometimes take 20 years. So being proactive is important. And also the people who experience 3rd and 4th degree tears is there's a term called OASIS, which is obstetric anal sphincter injuries. And those people, especially if there's anybody that should be seeing a pelvic floor physical therapist, it's people who have a 3rd and 4th degree tear. Because again, if we can get in with that early intervention, then potentially it worsening and other conditions developing as a result can be prevented. But 3rd and 4th degree tears definitely increase your risk of developing a prolapse.
Interesting. Okay, that's really helpful to know. And that made me think when you were saying that I hear around pregnancy and those issues, people talking about something called the husband stitch. I don't know if it's in America, something we say in the United States or whatever, but husband stitch. I hear that. I don't hear people talking about prolapse.
Yeah.
They talk about the husband stitch, and so that's a shame, and it kind of reveals culturally where we're at and what we're really thinking about. It's kind of like we're concerned about the husband's perspective. It reminds me of with pelvic mesh, how the FDA approved it, and then they had a website, an intranet within the FDA. You could go to this like little mini website on the FDA website, and it talked about problems with pelvic mesh, but it really didn't highlight the chronic pain, the way it would cut into the woman's body, how it didn't help. It didn't talk about that. It listed, and I saved this and I highlighted it. It listed, can abrade the penis upon entry. Can injure the penis upon entry. So again, the perspective was such a male one.
Yes.
Husband stitch, pelvic mesh can abrade the penis. It's like, okay.
Yeah.
Okay, folks.
Yeah. Change.
And then another little bit of and again, not to diss the medical community. Gosh, we need them. We need them so much. And love our medical advisors that help us with Kegelbell. And so we depend on them. But it's not the answer for everything. When it's a fitness problem or something that can be addressed with fitness, we don't need to, it doesn't rise to the occasion of a medical event. And I think most doctors would prefer that we solve it and not come to them with issues so far gone. So that just is something that really, shocks me about women's pelvic floor health. It's so often seen from the male gaze perspective.
Right.
And I was at a medical conference of urologists and pelvic floor experts, and there was a talk on hysterectomies and the 3 ways of approaching it: full, partial, and then coloplesis, which is where you just sew up the entrance to the vagina entirely. Like you just close the door, board it up. And so there were 3 doctors defending the 3 positions and talking about it. And I bring up hysterectomies because if the uterine prolapse is not addressed, the solution is to remove the uterus. And this could happen young in life when someone still may plan to have more children.
Yes.
So that's a grave concern.
Yeah. Yeah. And the thing with a uterine prolapse, uterine prolapse and then a hysterectomy is the uterus acts kind of like a bit of a keystone organ. And when it's removed, there's a void there, and things have now been suspended elsewhere. And if the person doesn't have the knowledge that they are at an increased risk of other things now prolapsing into that space, then they can just wind up needing another surgery or dealing with another prolapse. So it's again that information sharing that needs to happen. And there are an amazing doctor who I adore is Dr. Bruce Crawford out of Reno, Nevada, and he is a urogynecologist and was performing surgery after surgery after surgery. And he just said, sometimes it's the same person. They've been on my table before, and I think I'm a decent surgeon. So what's going on here? And he looked at it, and his saying, you just mentioned fitness, and reminded me, his saying is bladder control is a fitness issue. And I would say that the same with prolapse as well. And so he's actually now no longer practicing and focusing strictly on his exercise therapies for pelvic health, which I think is amazing. So we need the medical community, and hopefully there's more people like him who appreciate the collaboration between pelvic floor physio and who also are looking beyond surgery and who are looking at what's the root cause here and how can we address that. And potentially maybe the surgery is still going to be the best option, but let's get the pelvic floor in the best possible state, condition, function before surgery to improve that outcome, and have that person aware of ongoing care now for the pelvic floor. So the outcome remains. It's not something that they need to have repeated over time.
Yes. That's good. I want to check out that doctor for sure. Thank you. It reminds me of this one doctor who does what's called vaginal rejuvenation.
Yep.
And I was looking at his website, wondering what he was doing toward that end, what that could be. And he said there, before surgery, I think it was 6 weeks before, do Kegel exercise leading up to surgery, and then know that forever after surgery, you're going to have to do Kegel. And whatever he was doing surgically that was being called vaginal rejuvenation, I'll suspend or bracket that discussion. But I really appreciated his way of saying, true strength and rejuvenation comes from healthy toned muscles.
Yes, exactly. I love that. That's great.
And so I do, there are lots of doctors out there, and I work with them, and we have them as medical advisors. But, doctors that call me about Kegelbell and because they're interested, there's almost like a confession moment. Yeah. They say, the medical training was lacking, and these issues curiously fall betwixt and between OBGYN and urology. Mm-hmm. They fall between gynecology and urology into this like empty space. And it's just kind of a historical fact, like an anthropological, bizarre event that it happened that way.
Yep.
And so it's to no fault of theirs and their training. So I think there's going to be a change. I saw at the medical conferences, they were celebrating finally having women amongst their ranks. I mean, it was urology in particular was very male dominated. So I think there's going to be some changes there, and with PTs, physical therapists, which we celebrate and love at Kegelbell, and love partnering with, and love recommending that women go see them. It's the smallest subset, the pelvic floor PTs, but the fastest growing.
Yes, yes, which is amazing.
We have a lot of reason to have hope, but it is really hard for a woman right now in the United States, even in one of the major cities like Phoenix, to find an expert.
Yeah.
So there's changes going on, but we're part of those changes. And so I really appreciate you sharing all that you know, so that women can learn about prolapse, find out that there's ways of treating and preventing it, and hopefully can avoid surgery wherever possible.
Yeah. Yeah. Well, thank you. This is, I think we're kind of hopefully demonstrating the importance of collaboration as well, and getting people in that same like mind to help more.
Indeed. Thank you. See you the next series.